Today we're going to be talking about arterial blood gases, and the next part will be on acid-base, or depending on how much we get through. Okay, so you have a 25-year-old female who comes into the emergency room. She has this blood gas. Okay, so what do you think her most likely diagnosis is?
Drug overdose.
Drug overdose. Okay, so, and you say that because she has?
She has respiratory acidosis.
Okay, significant respiratory acidosis. So, drug overdose. Okay, so that's a good bet. So, the next question is, do you think she aspirated? This is on room air. This gas.
She could.
She could have.
Yeah.
Do you think she did? Is there any way to tell or any way to have a better idea of whether she did or didn't from the blood gas?
Hypoxemic.
So she's hypoxemic. So do you think that it's likely she aspirated?
It's likely from an increased CO2.
That what's likely from the increased CO2?
The
The low-
hypoxemia, the low
So you think it's
to
this
second
pure
range.
respiratory or hypercapnic respiratory failure, or do you think there's a component of hypoxemic respiratory failure?
Maybe the AA gradient.
Okay, good. So the way to tell would be to do an AA gradient. Okay. So how do you determine what an AA gradient is, or what's the formula?
It's 150 minus a sum of PO2 plus PCO2.
Okay, that's on room air, right? Okay, but that's based on and it's close. That's an approximation. That's not exact. So do you know where that comes from, that sort of rule of thumb? So you said that 150 minus the PO2 plus the PCO2? Is that what you said? Okay, so that is an approximation, but that's not really in it, but it's based on the true AA gradient. So in order to calculate the AA gradient, you have to know the alveolar gas equation. Do you know what that is?
The pressure in the atmosphere minus the pressure of water.
Okay, hang on. Minus the water vapor pressure. Okay, good. Times.
Times FiO2
Good.
minus PCO2 divided by 0.8.
Great. Okay. You're one of the first people that's ever gotten that right. Be proud of yourself. Okay.
Continuing.
Okay, so this is the alveolar gas equation. This is the alveolar O2. So for this patient, well, let's fill in the terms. So the barometric pressure is at sea level is what?
760.
Okay, and what's the water vapor pressure in the lung?
It's 740.
It's 47.
47.
And what's that FiO2 in room air?
20.
And what's the PCO2?
80.
And what's the respiratory quotient?
20.
20. Okay. So when you multiply this out, when you multiply this term out, you end up with what? 150. That's where your 150 comes from. Okay? So that's 150. And then what's 80 over 0.8?
100.
It's 100. So your alveolar O2 equals 50, right? The alveolar O2 is 50, so what's the AA gradient? So the AA DO2, or difference between the alveolar and the arterial O2 is what? You know, 50 is the alveolar O2 and 40 is the arterial, so your AA difference is 10. So 50 minus 40. So what what's a normal AA difference or gradient?
Less than 12, 10 to 12.
Yeah, it's sort of, it depends on age, okay? So as you get older, the normal AA difference increases. It's almost always less than 20 on room air. And a young person, it's usually less than 10. There's actually a formula to calculate to know what the normal is based on age. And that formula is, there's a couple of different formulas, but the one that I use, because it's the only one I can remember, is age times 0.21 plus 2.5. Okay, so in this case, this is going to be around 6 plus 2.5, about 8.5. So, and it's 10. So it's basically a normal. It's usually within a couple, you know. So it's a normal A gradient. So what does that tell you now? If she, now that you know she has a normal A difference, what does that tell you?
She likely did not aspirate.
Yeah, if she did, it's probably not a very significant one, at least at this point, right? So, because it basically tells you that the gas exchange is normal in her lung and she has normal oxygenation, and that the whole reason for the PO2 being low at 40 is because of hypercapnia, because of this reciprocal relationship between PO2 and PCO2. Why do we have that relationship in the lungs?
The partial pressure.
Yeah. So if you go back to the different gas laws that we all learned in college, you forgot. If you have a container, right, with a bunch of different gases in it, the sum pressure is equal to the sum of the partial pressures. And what are the different gases that are in your lung?
Nitrogen.
You have oxygen, CO2, what else? What's the other big ones?
Nitrogen.
Nitrogen, which is inert and doesn't exchange. What else? There's one more thing. In large amounts. And there's a lot of trace things. It's water, right? Water vapor, which is pretty constant. Okay? So really, if the pressure, the total pressure doesn't change, and although our lungs are not in a closed container, the the total barometric pressure is not changing, right? It's 760. In a sense, really the only thing that can change is the PO2 and the PCO2, right? That's going to have any effect. So if one thing goes up, the other one has to go down, right? So that's why there's this reciprocal relationship. Okay. All right, so one of the causes, so this is one cause of hypoxemia, right? Hypercapnia. We usually talk about 5 different causes of hypoxemia. So there's hypercapnia. What else? Big humus match. Okay, so low FiO2, which is basically altitude, right? And what's the fourth one? There's one more.
Diffusion.
Diffusion. Abnormality. Okay, so we talked about hypercapnic respiratory failure. That's a cause of hypoxemia. And, like I said, the way you can tell is to do an AA gradient. And so it's really worthwhile knowing how to do the AA gradient. And although that rule of thumb works pretty well when they're on room air, a lot of times you have people who are not on room air, and then you can't really use that, right? So it is worth knowing how to do the equation. And you can use a rule of thumb to try and figure out oxygen FiO2s, because that's then when they're on like a nasal cannula cannula or some other type of oxygen, you don't really know how much oxygen they're getting. But you can sort of guesstimate it because there are rules of thumb for that too. So what's the rules? Do you know how do you know what the FiO2 is or estimate the FiO2 for someone who's like on a nasal cannula or a mask? Simple mask.
3% for each 1 liter?
Yeah, okay, so 3% for every 1 liter of oxygen over, you increase the FiO2 by 3% over room air. So if you start at 21%, which is room air, if they're on 1 liter, it would be 24%, 2 liters, 27, 3 liters, 30, and so on, right? So, that's a rule of thumb. It holds true for most types of simple devices, oxygen delivery devices. So what are I guess it's probably a good time, before we get into this, why don't we just talk about the different types of oxygen delivery devices and how much oxygen they can provide, okay? So, how much oxygen can you usually deliver? Well, we'll name some devices. So I'm gonna erase this.
Nasal cannula,
Okay, so.
oxy mask, non-rebreather mask,
Okay, so you have
vapor.
nasal cannula. You have actually a simple mask. And you said oxy mask, which is a newer type of mask. What else?
Non-rebreather.
Venturi Mask.
Vapotherm.
Okay, okay, so these are probably the main ones that we have here. That they're probably covers most of the devices that are on the market, at least the major ones. So nasal cannula, you can basically get up to about how much oxygen just with a regular cannula if you're not using a vapotherm device.
10.
Usually about 6 liters is about all anybody can handle with that because it's pretty drying and it's a lot of flow. So 6 liters is how much oxygen in theory, based on this. 6 times 3 is 18 plus 21, about 40%, 39, 40%. Now, when I say it's a rule of thumb and it's sort of an estimate, what is that dependent on?
If patient is breathing actually with their nose or their mouth.
Okay, so there's a small component of that, but most of, if there's no obstruction in their nose, whatever they're getting is what they're getting. That's going to go down into their lungs. So why would breathing through the mouth make a difference? Or why, is there anything else that would make a difference?
Like the diffusion or if there's
Secretions.
That's when we're getting down into the lung and getting into hypoxemia, but I'm just talking about in terms of the FiO2, the amount that's actually inspired. Why would it not be constant? If I put you on 3 liters and I put one of your patients on 3 liters, you're not necessarily going to get the same amount of oxygen. Why?
It's the breathing effort required.
Okay, so how does the way they're breathing make a difference?
They're not taking as much of breath, like as many breaths they need to take in a minute. Does that matter?
Well, that's what I'm asking. Does it matter? And how would it affect it? How would your respiratory rate affect the amount of oxygen you're inspiring? I mean, you're
It's
both
like
getting
6
3
liters, yeah.
liters, right? So if you're breathing at 40 and you're breathing at 12, a normal rate, is your FI on 3, and I put you both on 3 liters nasal cannula, are you going to be getting the same amount of oxygen into your lungs or not? You've never thought about this, I'm sure. And it's not intuitively obvious.
When you breathe faster, so you're not taking deep breaths, so it'll not go into the alveoli until.
But I'm not talking about I'm just saying what's getting into their lungs, not even getting to this stuff.
Do you spend more time in expiration when your respiratory rate goes up?
Well, chances are if you're breathing at 40, this is not a closed system, the nasal cannula, right? You're just putting these prongs in somebody's nose. And it gets back to sort of your mouth breathing thing. Okay, so if you're breathing through your mouth and you're panting, or you're breathing really fast, or you're even breathing through your nose really fast, you're going to be entraining air along with the oxygen that's going in, right? The faster you breathe, the deeper you breathe, the more you are breathing, you're going to be getting not just the 3 liters of oxygen, but you're going to be getting a lot of air with it, right? It's not like you're just breathing, even though that's 3 liters of oxygen, 100% oxygen at 3 liters per minute. But if you're breathing at a ventilatory rate much higher than those 3 liters, you're going to have to be sucking in a lot of air along with the oxygen, right? Well, what's that going to do to the FiO2? It's going to dilute it, right? So even though you're breathing at 40, you're getting actually a lower FiO2 than she is breathing at 12. Right? So why is her oxygen level staying high? Probably because of the PCO2. She's blowing down her PCO2, so the PO2 is going up. And some of it is the oxygen she's breathing in, but that's the difference there. So the amount, and that's why we call this a rule of thumb, because it's totally dependent on how the patient is breathing. It's not just dependent on the liter flow. If it was just dependent on the liter flow, it wouldn't matter what you put somebody on, what the patient was doing. If the FiO2 is it's not going to be constant. So even on the same patient, so if you're breathing at 12 and now I tell you to start breathing at 40, the FiO2 that's going into your lung is going to go lower. It's not going to go up. Your PO2 may go up, but the FiO2, the amount that you're actually breathing in, the fraction of oxygen that you're breathing in is actually going to drop compared to when you were breathing at 12. I mean, it's still going to be more than room air, right? Because you're still getting some oxygen. Does that make sense?
Mm-hmm.
So that's why we say it's a rule of thumb, but that's with normal breathing. And most patients we put on oxygen are breathing normally, or they wouldn't be on oxygen, right? Okay, so what about a simple mask? Simple mask is just a mask that has basically, 2 holes on the side. You just put the oxygen in, right? And oxygen goes in like that. Okay, so how much oxygen can you put through a simple mask? Right? What FiO2 can you achieve?
12 liters probably?
Usually about 10 liters is about the max, and so you can get 10 times 3 is what? 30 plus 21. So you get about 50%. Okay? So this is 50%, this is 40%. What about an oxy mask? What is an oxy mask? How is it different than a simple mask?
Instead of the holes, it has
it actually has big holes in it, right? If you look at it, it actually has another bigger hole here, right? So it's actually even more open than a simple mask. Yet you can get a higher FiO2 with it. It's curious, right? So just told you a lot of that FiO2 is dependent on how much air is entrained. So how do you get more oxygen with an oxy mask when it has more holes in the mask? Never thought about that either. Well, how much can you get with an oxy mask? Do you know? You can probably get up to around, they claim you can get up on a 15-liter oxy mask up to around 70 to 80%. Okay? So how does that happen if there are all these holes in the mask? One of the benefits of an oxy mask is it has that hole around the mouth so they can sip water and talk and you can hear them. That's one of the big benefits of it. It's more comfortable than a regular simple mask because of the extra hole there. So how does it work? Well, if you look at an oxy mask, there's a little nozzle in the mask that the oxygen actually goes through the nozzle. And that nozzle directs the oxygen directly into the mouth and the nose. So it's not just like going into the mask, it's actually oxygen flow is directed into the nose and the mouth, which increases the fraction that's actually going into the patient. That's how it works. There's nothing super magical about it. And, okay, what about a Venti mask? What's a Venti mask? You mentioned it. Do you know what it is?
I've seen them, but I don't know
Okay, so Venturi Mask is actually short for something, another one of those physics things that we all learned about and promptly forgot, called, I'm going to erase this, I'm going to put this back up here. So a Venturi Mask, do you remember learning something about something called the Venturi effect? Physics? I'm sure you all learned about it, probably forgot. Okay, so a Venturi mask, if you look at a Venturi mask, there's a couple of different types of Venturi masks. But basically, it's just a simple, what looks like a simple mask, and there's a couple of, like I said, a couple different kinds. So here you have the oxygen tubing, and then there's this yellow or a green collar on it, okay? And there's other types of Venturi masks where you actually change this piece to different colors. But the ones we have are just green, and then you basically, if you look at what's on there, there's writing on there, and then it'll say, it'll have a percentage, an FiO2 percentage, and it'll have a liter flow next to that percentage. And you basically dial that piece to whatever FiO2 you want, okay? But you have to also match the liter flow. So if it says 40%, 10 liters, then you have to set the wall oxygen at 10 liters, so the flow is 10 liters, and then it will provide 40%. If it's 6 liters, maybe it's 30%. I don't remember. It's on there. It tells you exactly what to do. Okay, so how does that work? Well, it works because there's a little. As you turn that to a higher FiO2, and the highest FiO2 I think is 50% for these masks. As you turn that, this hole that's in the mask sort of partially opens and closes depending on the FiO2. But what's happening there? What's happening is you're entraining air through there. As the hole gets bigger, you're entraining more air and the FiO2 is less, right? The Venturi effect basically says that the liter flow, the flow rate, basically drags oxygen in here through this hole. It sucks the oxygen into the hole. That's the Venturi effect. So that's why you have to put the precise amount of liter flow that's on there to get the FiO2 that you want. Because as you turn the liter flow up, more or less oxygen is going to get sucked through this hole. So you can get a very precise FiO2 into the mask. Venturi mask works, and you can get up to about 50%. So if you have somebody that you want to get a really precise FiO2 on, you want to use a Venturi mask, because that you can actually dial in the percent that you want. And it goes down to like 24%. So if you have like a CO2 retainer and you want to really precisely titrate the oxygen rather than using a nasal cannula, you can use the Venturi mask. So I don't use them a lot, but they're available, and that's really when we use them, when we really want to give a precise amount of oxygen. Okay. What about a non-rebreather mask? How does that work?
It's a bag attached to it.
A what?
The bag attached to it.
Okay, so you have the mask, and then you have this big bag. Okay, so what is that? It's also called a reservoir mask. Okay, so what does that mean? Well, basically, you're putting a reservoir of oxygen in here, and then the oxygen, it's not just the flow, you're not just putting 10 liters or 6 liters, you're putting a lot of flow through here, maybe 15 liters, but then it's filling this reservoir with oxygen. So you're basically just breathing pure oxygen through there, and they can use a very high flow rate. They can, have a very high demand. They can be breathing really fast, and they're going to get mostly oxygen and not air along with the oxygen, because it's not, your flow rate can be much higher than 10 or 15 liters if you're breathing really fast. Okay? Does that make sense? So that's how the non-rebreather works. That's why you can get higher FiO2s with it. Even though you're only putting 15 liters through here, you're getting actually much higher, potentially much higher than that. 15 times 3 is 45, so it's like 66. You can probably get 80 to 90% oxygen with a non-rebreather. So actually, probably somewhere between 70 and 90, depending on how the patient's breathing. Remember, none of these masks are tight-fitting masks, so there's always air, coming in through the sides of the mask. And also on the non-rebreather, there's 2 holes, but one of them has a valve on it. There's like a little flap that like a rubber flap. That's a one-way valve. So the patient breathes in, the flap closes. It doesn't entrain air through there. In the old days, in my time, when I was training, both sides had flaps. And so you could actually get higher FiO2s with that. And then they stopped putting flaps on both sides because there were a couple of incidents where people, I think, the flaps got stuck. And so the patients started rebreathing CO2. And they, had some incidents. So they basically said, well, that's not safe. We're just going to put a flap on one side. That way the other side is always open and you're not going to build up the CO2. But occasionally we would just like find another mask and take this flap off and put it on so we could get a higher FiO2. Not supposed to do that. Okay? So these are the different oxygen devices, and that's kind of how much oxygen they can deliver. And that's why the flow rate is really important, but also how the pattern that the patient's breathing in is really important. Because you're not going to, and that's why that rule of thumb is just a rule of thumb. Okay, with the 3% per liter.
Vapotherm?
I talked about vapotherm, didn't I? Oh, no, I didn't. I talked about the oxygas. Okay, so vapotherm, what is that? Have you looked at it? It's just a cannula, right? There's nothing special about that. But you can get very high FiO2s with a vapotherm. So why is that? How do you deliver oxygen? How much oxygen goes through a vapotherm? Remember I said with a normal cannula, you can't put more than like 6 liters per minute through there? What is it for a vapotherm?
40.
You can go up to 40 liters. Okay, so why can you do it with a vapotherm, but you can't do it with a regular cannula? The cannulas are almost the same. It's not really the cannula that you're using, right? It's the vapotherm device is the thing next to it, right? So you can titrate the FiO2 through that, but you can also titrate the liter flow. You can go up to 100% oxygen, which all of these things are. They're all using 100% oxygen, right? When you have 3 liters per minute on a nasal cannula, that's 100% oxygen going through that cannula. It's just at 3 liters per minute. Well, with the vapotherm, you can go up to 40 liters per minute. What basically all the vapotherm does 2 things. One is it humidifies and warms the air, so it's very comfortable for the patient, so that when they get this high flow rate, it doesn't dry everything out, and it feels very comfortable. So that's a really good thing, and that's why you can use such high flow rates. Otherwise, you'd never be able to do that through the cannula. The other thing it does is it's an oxygen blender, so you can actually titrate the FiO2 that you want of the what's being delivered. You can also titrate the FiO2. So you can have 40 liters at 100%. You could have 40 liters at 50%. Well, 40 liters at 50% is like having, 20 liters at 100% would be almost like 50% oxygen. I mean, you're titrating 2 different things, and it's different depending on what you're titrating, and then it kind of becomes confusing. Which do you titrate? If you're trying to titrate down, do you titrate the FiO2? Do you titrate the liter flow? I think a lot of it depends on how fast they're breathing. Remember, the faster they're breathing, the more liter flow they need. Once they're slowing down and getting better, they probably don't need that kind of liter flow. So you can just go down on the liter flow. Or you can cut the FiO2, but then you don't really know what they're really getting at that point. So it does become confusing, but it is helpful, and you could probably get up to about equivalent of about a non-rebreather mask. So probably somewhere between 70 and 90% oxygen with vapotherm. And sometimes you have people, they put on a vapotherm, they're on 40 liters, and then they slap a non-rebreather mask on top of it. It doesn't really make a lot of sense. Their FiO2 may go up a tiny bit because they have that extra reservoir of oxygen, so maybe they're breathing more than 40 liters per minute in, and so they're getting that extra. It's going to be oxygen instead of air, but it's not really going to, at that point, those patients need to be intubated, usually, or put on non-invasive ventilation, which is like BiPAP. The other thing I usually talk about well, a couple things. So, getting back to the A gradient, one of the benefits of it is you can sort out how much of this is just hypercapnia and how much of it is really hypoxia or really a problem with the lungs. And one of the things I usually tell when I give this talk is that when I had my private office practice, I would usually once or twice a year get a consult from usually orthopedic. It was almost always orthopedic surgeons. And they would call me up and they'd go, "Hey Jeff, I have this patient, I did a hip replacement or a knee, on like 4 days ago or 5 days ago. And we can't get the patient off oxygen. Every time they try and wean the patient off oxygen, they desaturate, and I'm afraid that maybe the patient had a pulmonary embolism." So I would say, "Well, did you get a chest x-ray?" No. So, did you get a blood gas? No. So, well, why don't you get a chest x-ray and a blood gas and on room air, and I'll come and see the patient. So I would come to see the patient, look over the chart, examine the patient, can't really find anything, no history of COPD or lung disease or any reason why they should be hypoxic. Look at the chest x-ray is clear, but certainly it could be with pulmonary embolism, right? And the timing is always about right, 4 or 5 days, 3 to 5 days after a, lower extremity surgery, that'd be about right for pulmonary embolism.
Low battery.
And at that point, I would just go ahead and look at the blood gas. And look at the blood gas and I calculate the A gradient. And the A gradient almost always was normal. So what did that tell me?
Anesthesia maybe, or pain meds.
Yeah, and it tells me that there's probably not a large pulmonary embolism, which we'll talk about in a second. And B, it's mainly due to hypercapnia. The CO2 would be like 50, 55. PO2 would be down, around 50 or 55, and that's why they kept needing a couple liters of oxygen to keep their saturation up. So they're hypercapnic because of pain medication. So you go and you look and see that they're on a PCA pump, or they're on some other kind of continuous pump, or they're getting a lot of narcotics for their pain, and you basically just say, stop the pain medicine or cut it in half or whatever, and get another gas in a couple hours. And, almost always that was the end of it. It's a very easy consult. It's a good thing that orthopedic surgeons don't know how to do AA gradients. That's what we call them consults. So, it can be helpful clinically. It's not just an exercise in whatever, mathematics or physics. The other thing that I usually talk about when we talk about the reciprocal relationship is there's a paper in the articles database for critical care if you're interested in it. Is anybody, either of you, like mountain climbers? So there's an article in there on that was written, I don't know, probably 4 or 5 years ago now, on a bunch of climbers that climb Mount Everest. They did blood gases, not quite at the summit, but close to the summit of Mount Everest. Now, a lot of people climb Mount Everest now. It's supposed to be like a freeway up there, and there's lots of bodies strewn along the trail apparently also, because most of the people that are climbing it have no business doing that. They think it's some kind of, vacation or something. I don't really know what they're thinking. But there are very few people that have climbed Mount Everest without oxygen. And but they did this study of 6 climbers, and they did their blood gases near the summit, and then they brought the gases down to one of the lower stations, and then analyzed the blood gas. They carried the equipment up there. So what do you think their PO2s and their PCO2s were near the summit of Mount Everest?
Both low.
Yes, both low.
Yeah.
So how low? What do you think their PO2s were? Their arterial O2s?
50.
50. What do you think?
I have no idea.
Definitely low, but I don't know how low.
Well, they were like I think around 28 to 32 or somewhere in there, in the low 30s, high 20s. That's their PO2, their arterial oxygen. What's a normal mixed venous oxygen?
65.
Well, the SAT, but do you know what the PO2 is? The PO2.
50?
75% saturation is equivalent to what PO2, do you know? That's a normal mixed venous, actually.
50?
40.
For 40.
So their arterial O2s were lower than a mixed venous O2, which is your venous blood. So their arterial O2 was lower than that. And what do you think their PCO2s were? You said they would be low. How low?
Yeah.
Because they're going to be hyperventilating
Yeah.
to try and maintain the PO2 at this very high altitude where the FiO2 is very low. That's the fifth thing, right? We talked about the 5 causes of hypoxemia. The fifth one was the high altitude, low FiO2. So this is the state that they're in, right? So what do you think it was? What did you say?
20 maybe?
20?
10 to 20?
And 25, 30.
It actually ran, I think if you look at the article, somewhere around 8 to 12. And the people, the climbers that could keep it down at 8 were able to stay up there longer. The climber that was 12 or 13, he couldn't stay up as long because he couldn't get his PO2 up as high, right? Because he couldn't ventilate enough to keep his CO2 down and his PO2 up to maintain that. He couldn't do it. Even though these were all super fit climbers, you know, there were slight differences between people, right? And the one that couldn't, you know, could stay up there the least was the one that just couldn't hyperventilate enough. So it's pretty remarkable. Probably if Mount Everest was any higher, you could never climb it without oxygen. A person could never do that. Okay. When you get back to the 5 causes, so of hypoxemia now, you have the hypercapnia, we talked about EQ mismatch, talked about shunt, diffusion, abnormality, and then
Altitude.
low FiO2, okay, or altitude. Oh, one thing I just wanted to come back to, because I kind of mentioned it when I gave that story about orthopedic surgery patients, about the pulmonary embolism. So you probably have heard that you can't rule out a pulmonary embolism with a blood gas, right? I'm sure you've heard that somewhere along the line. You've been taught that. What is that based on? Do you know? Because in theory, I mean, if you have a pulmonary embolism, you should be able to get, you should have an abnormal PO2, right? In theory. So why can't you rule it out with blood gas?
There might be the blood delivery to areas where it is like having good oxygenation. So that might decrease the AA gradient. So you might not see an AA gradient with it.
Well, one of the things, that statement is based on a big study called the PIOPET study, which was done back in the 70s or early 80s, which was the first really big study of pulmonary embolism, where they did VQ scans and they did pulmonary angiography and blood gases and all this stuff. When they analyzed the study, they looked at blood gases and they looked at PO2s initially, and they found that PO2s were often in the normal range. A small percentage of those patients had normal quote unquote PO2s. Okay, so that's why they say you can't rule it out with a blood gas, even though they have a normal PO2. Well, the reason is most of those people are actually hyperventilating to maintain their PO2s in a normal range. When they reanalyzed that study, the same study, they went back and looked at the data and looked at AA gradients instead of just the PO2. Then they found that number that were normal dropped significantly, and there were actually only a few patients in the entire population of a couple hundred patients, I think, that actually had a normal AA gradient. So, and those people had very small pulmonary emboli, like very, like small segmental or subsegmental emboli. So, I think it's true that you can't totally rule out a PE with a blood gas, but sometimes we get these patients in the emergency room, they're in shock, and they're severely hypoxic, and they're going, you know, do they have, or they're in shock, and they go, well, maybe it was a massive pulmonary embolism, and you do a blood gas, and if they have a normal A gradient, that's not they're not having a massive PE, okay? If you have a massive PE, you're not going to have a normal blood gas, period. So yes, you can miss a very small PE, probably, you know, you could even question how clinically significant it is with a normal blood gas, but, or at least a normal A gradient, I should say. But a large pulmonary embolism, you're not going to miss, okay? But remember, you need to do the A gradient, not the PO2. Okay, so what is diffusion abnormality? We have a few minutes left.
Like a sarcoid or
So the paradigm for diffusion block is what condition? Sarcoid can do it. What else?
Pulmonary fibrosis.
Pulmonary fibrosis is sort of the condition that everybody, pathognomonic, whatever. But certainly you can get it in other things, any kind of interstitial fibrosis, or thickening of the alveolar capillary membrane. Patients with pulmonary fibrosis very often, when they're sitting and not doing anything, have normal PO2s. They seem fine. But as soon as they start walking or exerting themselves, they desaturate extremely quickly sometimes. Why does that happen?
Is it because the arterioli dilate and there's more flow? I think I'm thinking of hepatopulmonary.
Yeah, it doesn't dilate, but there is more flow. Okay, so because they're exerting themselves,
There's
if you have
increased flow
if
and
you have
there's
an
less time.
alveolus, yeah,
There's less time
there's
for
less
the oxygen
right.
to.
So normally, you know, maybe within a third or the first half of the capillary, as the flow goes this way, you're going to equilibrate the oxygen, right? If they have pulmonary fibrosis, and this distance that it has to traverse is now, you know, here's the blood now, and now you have this thickening in here. It's got to it has to go farther. So maybe when they're resting, it's 3/4 or 80% of the way, and as soon as they start exerting themselves, the blood flow increases, and now it's out here. So it never fully equilibrates because there's just too much flow, and there's too much distance for it to traverse. So we don't, in the ICU, don't see a lot of major problems from diffusion. There's not, I mean, occasionally we get pulmonary fibrosis patients, but it's not a big problem in the ICU setting usually. But it is one of the causes of hypoxemia. What about shunt and VQ mismatch? What is a shunt, first of all?
The blood is shunting through the alveoli that is not being oxygenated.
Okay, so there's, talk about ventilation and perfusion. You have no ventilation and you have normal perfusion. That's a shunt, okay? So what are some examples of a shunt, conditions that cause a shunt?
Atelectasis.
Okay, atelectasis, what else? ARDS.
Pulmonary edema, anything that would fill up the
Okay, good.
alveoli.
Anything that fills the alveoli with
Blood,
blood, anything, or collapse.
Pneumonia.
Or collapse, like an atelectasis, is going to cause a shunt, right? So cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, ARDS, atelectasis, mucus plug causing atelectasis, you know, that's all going to cause a shunt, okay, because you have no ventilation here. What's the opposite of a shunt?
Have
The
no
opposite
flow.
is 0, is 1/0, right? Ventilation but no perfusion. So so you have no perfusion.
PE.
So a pulmonary embolism is supposed to be the sine qua non of a, and what is this called? The opposite. What's that condition called? So this is a
Oh.
shunt. What is this called? Where you have
That's
ventilation,
dead
but no,
space.
it's dead space ventilation, right? Okay, so between here and here, we redraw this down here. Like this. So between these two extremes, somewhere along here, you're going to have VQ matching, right? The ventilation and the perfusion are going to be matched. And what about on the rest of this line? What is that called? It's VQ mismatch, right? Anywhere else on this line other than this line of identity, if you want to call it that, where the ventilation is matching to the perfusion, or the perfusion matching the ventilation, anywhere else on this line, on this side you're going to have less ventilation, on this side you're going to have less perfusion. That's all VQ mismatch, right? So that's why A, VQ mismatch is the most common abnormality. B, remember we're looking at single alveoli here, and nobody has 100% shunt or 100% VQ mismatch, or you're kind of looking at a composite of all of the alveoli. They have mostly shunt, or a lot of shunt, or a lot of VQ mismatch. So when we talk about it, you have to remember nobody's pure. But you're going to have somebody with VQ mismatch that has a lot of alveoli here, and a lot of alveoli here, and maybe some here, and a small amount there. But overall, it's going to be VQ mismatch. How do you tell the difference clinically between shunt, predominant shunt, and VQ mismatch?
You have oxygen.
So you give them oxygen, you give them supplemental oxygen. What happens if they have VQ mismatch?
If they have a shunt,
Okay, let's start with shunt. If they have shunt, what happens if you give them 100% oxygen?
it can improve.
Can improve or can't?
It can.
So I put 100% oxygen in here, and here's the blood flow. Is their oxygenation going to improve in this capillary out here?
You can shift it towards,
How do you do that?
well, if it's ARDS,
There's
you
no
get
oxygen
more.
getting in here, right?
No.
You can put 100% oxygen in here, and it's never seeing a capillary. So for a shunt,
Just not.
it does not increase the oxygen level, the PO2, because of that. It doesn't matter how much oxygen you put in here, it's never going to get, this alveolus is filled with fluid or it's collapsed. It's never going to see this blood, right? So with a shunt, oxygen doesn't really help much. And yeah, it's going to go up a little bit. Maybe you go from 50 to 60 because why? Well, because like I said, not everybody has you don't ever have 100% shunt. You rarely are going to see anybody with more than a 50% or 60% shunt. Otherwise, the patient would be dead, right? Again, with no oxygen in their blood, if you had 100% shunt in all your alveoli, you'd have basically somebody without lungs, right? No ventilation at all. Okay, so, but with VQ mismatch, if you have, some abnormality here, but at least some oxygen can get in here, even though you have some obstruction, or if the alveolus is partially collapsed but not completely collapsed, as long as you can get oxygen in there, then some of it's going to get to the blood, right? So you're going to be able to overcome, you should be able to overcome VQ mismatch with oxygen, at least partially, whereas with a shunt, it's much, much harder. Okay. All right, do you have any questions about any of this? 'Cause